Hi guys. Okay, we're gonna go ahead and get started because we've hit the top of the hour. And I was going over Lauren's slides yesterday, and we have got a lot of really exciting, which I can say because I'm a nurse, and so I can say it's exciting, even though it may feel a little overwhelming right now. Hopefully, by the end of Lauren's webinar, you're gonna feel a lot more comfortable. But specifically today, we're focusing on pharmacology for pain management. And this one was really overwhelming subject for me in nursing school. It's something we really wanted to focus in on in our review for nursing school, and we created that just because of how important pain management is. We know that there's a ton of studies showing that when our clients have good pain management and good pain control, they are less likely to have infections. They're more likely to move. They're less likely to gain weight. They're less likely to relapse, to be addicted to pain medication. There's all sorts of studies that show the importance of managing pain in our clients. And so it's a really important subject. And there's a lot of different ways we manage pain. Obviously, you have the non-pharmacologic route with things like acupuncture, icing, heating, massage therapy, all sorts of things we can do that aren't medications that manage drugs. And today we're going to focus in on the prescription medication over the counter, an actual pill that someone is taking, whether it's injectable, something they're swallowing, a medication that is meant to manage pain. So we're going to focus in on opioids, NSAIDs, and adjuncts. So I'll turn the time over to Lauren, but first off, just a quick little pitch for you guys. All of this information and these slides that Lauren is covering are available in Archer Review for Nursing School. And we just launched that a few months back in September of last year. We now have 20 comprehensive courses. And if you guys are joining now at this point, you may already know about Archer Review for Nursing School. And we wanted to just make nursing school a little bit simpler for you, because we know nursing school is super overwhelming. We know you guys are coming from all different backgrounds. Some of you are parents. Some of you guys are still living at home with parents. Some of you guys are working one full-time job, two full-time jobs, three jobs to try to provide for yourselves or your families. And we understand that since everyone's not coming from the same background, the same country, even speaking the same first language, the importance it is to try to make nursing school as simple and understandable as possible, because our goal at Archer is, of course, for you guys to all reach that dream. And so, Lauren, if you'll hit that next slide for me, with those 20 courses that we have made for nursing school, the focus is really in on mini lectures. So we took all of the content that you're learning in your nursing program and have really broken it down. So whether you're in your first semester of nursing school, you're still a pre-nursing student, or you're your last semester and getting ready to prep for the NCLEX, this is going to be a really strong product for you. Every little piece of information has been broken down into short videos. So say you struggle with heart failure. Well, we have, a 5-minute clip on heart failure. Say you struggle with immunizations in pediatric population, our pediatrics class talks about that. And so each of these 20 comprehensive courses follows along where you guys are in nursing school, and it's meant to be really buildable to what your needs are. And then with that, you can go ahead and test yourself as much as possible. We've made a Q bank of over 5,000 questions. We wanted those 5,000 questions to be NCLEX style, to really try to get you prepped for as you start studying for the NCLEX. And then we've also made cheat sheets. And that's the last thing I'll touch on here before I turn it over to Lauren. But just these cheat sheets are 1-2 pages max of illustrated from our medical illustrators, designed by our design team to be really engaging and to summarize that super important information. So I'm a visual learner, so I'm sure you guys can guess cheat sheets was kind of my baby. I was like, we have to have cheat sheets. No one wants to sit and listen to 3 hours worth of lectures on this stuff. Summarize it in tables for me. Give me pictures. Give me mnemonics to memorize. And so with that, we've made all these cheat sheets to make things as simple as possible for you guys. You can print them, download them on your iPad, on your computer, whatever is your easiest learning style. You guys are going to love those. So you can go ahead and sign up for Archer for Nursing School right here using this QR code. Or if you guys are on your phone joining today, you can go ahead and just go to archerreview.com and you can find our nursing school product there. You can buy in a bundle and buy all the courses together, all 20, or you can pick and choose the courses that you need. So that's all I'll say about nursing school for now. But to give you a little sneak peek of the information you'd be getting in Archer Review for Nursing School, I'll turn the time over to Lauren. She is our resident expert on all things pharmacology. I graduated with my doctorate. I'm a nurse practitioner. I'm pretty sure I would still call Lauren up if I had a drug question, because she is amazing at it. And she actually helped create the pharmacology course for Archer for Nursing School. So if you love her content here today, she is smart as a whip, and she has lots more to share with you guys in the pharmacology course. So over to you, Lauren.
All right. Well, thank you, Annalise, for talking me up. And welcome to everybody who is here logged in. Like Annalise said, we're going to mainly focus on the pharmacological side of pain management today. We're going to talk about opioids first off, which is where we're going to start here. And then we're going to move into our NSAIDs, and that includes aspirin, and then we'll talk about Tylenol, and then we'll talk about some adjunct medications and muscle relaxers at the end if we have time. So that is how today's going to go, and I only have you for an hour, so I will hit the main highlights here on these slides. Um, so as Annalise said, there are a lot of non-pharmacological things that we can try for pain first, and those are always used in addition to our pain medications. We don't want to just throw medications at things. And as we talk through these medications, I'll talk through, reasons why we shouldn't give them and how we should be cautious because pain medications have caused some pretty severe problems over the last few years. And so it is important as nurses and nursing students, as future nurses, that we understand how to give these safely and how to teach patients to take them safely. So we're going to start talking about opioids because they are a huge part of pain management. But first, we need to talk about some vocabulary, just some little words that we need to understand. So the first thing is opiates. So all opioids and are opiates. They are made from poppy flowers. Opium is a substance that is extracted from poppies and it creates opium. This is why in the early 1800s or so, there were things like opium dens. There were a lot of people that were smoking this, things like that. So all of our opioids are opiates. So opiates just refers to anything that comes from the naturally occurring opiates in poppies. So you might see that word used. You also might see us call them just opioids. Opioids are typically what we call any opioid derivative in pharmacology. So any medication that is derived from opium or is synthetically similar is going to be an opioid. Now, you also will hear the term narcotics. Narcotics are usually, this is a term that's usually used by law enforcement and in more of the legal world to describe medications that alter perception and sensation. So this includes opioids, but it is not exclusive to opioids. So just be aware of some of those terms because we might kind of throw those in there. And then just as a fun fact over here, the word narcotic actually comes from the Greek word for stupor. So if you are talking about a narcotic, these are usually medications that are going to put people to sleep. In general, these are CNS depressants, and that is how they treat pain. They just depress the central nervous system. We have three different types of receptors for opioids in the body. We have mu1 and mu2, we have delta, and we have kappa. Now, for nursing school and the NCLEX, it isn't imperative that we know these receptors in and out. But if we understand that some receptors are activated by certain opioids more than others, then you'll understand why some opioids have more pain control than others, why some of them have more constipating factors, and why some actually block some of these receptors when we're talking about drugs that treat opioid dependence. And we're going to go through all those today. So these three types of receptors, and it's not imperative that you have these memorized, but just be aware of them. Most of our opioids are going to work on our mu and our kappa receptors. Our delta receptors are a little bit less common for stimulation. But when we stimulate these receptors, we release endorphins. So that is how opioids work in the body. They stimulate these receptors and they release these endorphins. The word endorphin actually is a mixture of endogenous and morphine. We didn't even know endorphins existed until after morphine was synthesized. So endorphins, that release of those endorphins is what actually causes the pain relief when you give an opioid to a patient. Um, and this just blocks pain receptors. It blocks the body from feeling that perception of pain. So opioids are good for blocking pain, but they don't really treat it. And that is what is kind of the crux with opioids. They're not anti-inflammatories. They don't tamp down the immune system. They don't help with the root of the pain. They just mask it, which is why these are falling out of favor when we are prescribing pain medications, because they don't really treat the pain. They just mask and change our perception of it. But they have a really good place in the hospital post-surgery and whenever someone is in acute pain and in hospice care. So these are really important drugs, and you will give a lot of these over your careers. Um, so that is really the basic stuff behind your opioids. They also close calcium channels, and they make our nerves less excitable, and they open potassium channels, and so our cells cannot respond further to pain signals by hyperpolarizing the cells. But what is most important nursing wise is to understand how to give these medications safely and how to teach patients to take them safely. All opioids, as I mentioned earlier, are CNS depressants. So they are going to decrease your brain function, and they're sedatives. So a lot of these are used in conjunction with anesthesia to give better pain control, but also to sedate. And so we have to monitor always, always the airway. That is number one with your opioids, is to monitor the airway, because all of these are going to cause respiratory depression to some degree. So these these medications, things like morphine, which is the prototypical opioid, it's one of our earliest opioids. We also have fentanyl, which is the strongest opioid that we have. It's about 80 to 100 times more potent than morphine. So this one is given in micrograms versus milligrams. We also have hydromorphone. This one's better known as Dilaudid. We have oxycodone and hydrocodone. And then a lot of times these last two, oxycodone and hydrocodone, are mixed with Tylenol to make Percocet and Norco, if you know the brand names. Now, for the NCLEX and in nursing school, we mainly focus on generic names, but sometimes we'll throw out those brand names because they are a little bit better well known. So your Percocet has acetaminophen in it. That's why it's called Percocet. And then you can get your Vicodins and Norcos. Those are also often going to have Tylenol in them as well. And we'll talk more about Tylenol a little bit later, but it just adds to the pain relieving effects of the opioids. So as I mentioned, with all of those, you're going to be monitoring sedation and you're going to be monitoring the airway. We need to know what their oxygen levels are. We need to know what their blood pressure is. We need to know what their heart rate is, because these are going to slow all those things down. We also always need to watch for constipation. As these are blocking those pain receptors, we also have some of those mu receptors in our gut, and so they will block peristalsis. So these drugs are really well known to cause constipation, and even in severe cases, they can cause complete paralysis of the bowel. This is why after surgery, when patients are on these opioids, it's so important to get them up walking, to make sure they're drinking plenty of fluid, and to give things like stool softeners, because it will really, really help get their bowels moving again. These also can cause urinary retention as well as hypotension because of the way that they're working, and that urinary retention similarly goes with that decrease in peristalsis. Now, overdose. Opioids, we're in the middle of an opioid epidemic, and we have been for several decades now because these were overprescribed for so long. So overdose deaths due to opioids are very common, unfortunately. And so the overdose leads to respiratory arrest, which leads to cardiac arrest. And so we always want to identify when someone has overdosed on opioids or we've given too many of them, so that we can prevent that cardiac arrest. The antidote for toxicity, and this is very important for the NCLEX, it's a heavily tested thing, is naloxone. You might know it better by the brand name of Narcan. Naloxone can be given IV, or it can be given via a nasal spray if you're outside the hospital, and it reverses and blocks those receptors, those mu and those kappa receptors, and so the opioids will be knocked off those receptors and they won't work, and that respiratory depression can be reversed. So naloxone is an amazing drug for that. But when we give it, we have to be very careful to monitor patients for withdrawal symptoms, especially if they were on opioids chronically, because we just took them away. We just cut them off. So you're monitoring for irritability and anger when they wake up, Seizures can occur, things like that. You are really on the lookout for those. Some other things about opioids that are universal: fall precautions. These patients are always a higher fall risk because we are changing the central nervous system. We are depressing it. So these patients can get dizzy, they can get hypotensive, and they can fall. And then all of our opioids are compared to morphine because morphine is the first opioid that was used widely. So all of our opioids, we say, oh, this one's this much stronger than morphine, or this much stronger. And like I said earlier, fentanyl is our strongest, and it's 80 to 100 times more potent than morphine, which is why we have to be really careful with fentanyl. All right, so a recap of some of our opioid side effects and some things that we didn't talk about. All opioids cause pupillary constriction. So if someone is overdosing on an opioid, you'll often see pinpoint pupils. That's very common. They'll be very out of it because of that sedation. There's respiratory depression. They will also have reduced salivation and just dry mouth. Um, Pruritus, that's itchiness. A lot of times these opioids will cause people to become itchy. And some people will say, oh, I'm allergic to that because it made me itchy. And that isn't always wrong, but it's not really a true allergy. It's more of a reaction to the medication. These can cause respiratory depression, which can lead to pneumonia and things settling in the lungs. And if anybody throws up when they are respiratory depressed, they are a high risk for aspiration. This is why after surgery, when someone's had opioids as well as anesthesia, we are always monitoring that airway because aspiration can occur. A lot of opioids can also make people nauseated, which makes them a high risk for aspiration as well. We don't want people to throw up when they cannot manage their own airway. They can also cause hypotension and the headache. The headache is due to a lack of blood flow to the brain. And then we get that constipation, urinary retention we already talked about, as well as the emesis. Those are just some common side effects. Um, as I mentioned, they are CNS depressants, so we want to avoid giving opioids with any other CNS depressants like alcohol or a benzodiazepine. Those are anti-anxiety drugs. We only give opioids with other CNS depressants in really controlled situations, like in surgery when we're monitoring every vital sign, and they're on a ventilator and we are oxygenating them. We always avoid these in head injuries because they mask the signs and symptoms of increased intracranial pressure because they are tamping down our central nervous system. There are a few really distinct times when opioids are given that we wouldn't typically think of because usually we think of these as pain medications. In pediatrics, morphine is commonly given in tetralogy of Fallot, which is a congenital heart defect where they have right ventricular hypertrophy due to pulmonary artery stenosis and atresia. And so morphine is given to these babies that have this tetralogy of Fallot to actually reduce the blood pressure in the pulmonary artery. And it allows them to oxygenate better. So in those babies that have tetralogy of Fallot, it actually helps with oxygenation and respiratory function versus being a respiratory depressant. So that is one time where it is kind of given that we would not typically think about that being a typical treatment. The weakest opioid we have is called tramadol or Ultram is usually the brand name. And it is more on par with some of our stronger NSAIDs, but it's not an anti-inflammatory. It's just the weakest opioid. So typically it is a little bit safer than some of the really strong ones if we are worried about patients getting dependent or addicted. Sometimes opioids are also used as cough suppressants. There is an opioid called codeine that is commonly put into cough syrups that is used as a cough suppressant because when we're respiratory depressing, you can also decrease the drive to cough. So these are known as antitussives. There is also a derivative, it's a cousin of the opioids. It's called dextromethorphan that is in over-the-counter cough suppressants. But we have to be very careful not to give cough suppressants that have opioids or any of their derivatives to anyone under 18. And we really don't give dextromethorphan to anyone under 6. So those are some important distinctions. We also can give opioid derivatives as antidiarrheals, so Lomotil or loperamide, Imodium. Those are opioid derivatives, but they've just taken the constipating part of our opioids out of the medication and they put it in its own form. So it helps stop up that diarrhea by decreasing the peristalsis. So we've used a side effect and made it into a intended effect. And then fun fact, not so fun fact really, heroin, the drug heroin was actually created when we were trying to make a drug that was less addicting than morphine, but had better pain control. But they accidentally made heroin and it is 3 times more potent and it's much more addictive, so we cannot use it medicinally. So heroin is technically an opiate, but there is no medical use for it. All right, let's go a little bit more in depth with fentanyl, because this is one you guys are going to be giving a lot as nurses. Fentanyl, as I mentioned, is really potent. It's 100 times or 80 to 100 times more potent than morphine. So it is given in micrograms and not milligrams. It can be given IV, orally, or in patches. Fentanyl patches are a really good choice for patients who have round-the-clock horrible pain, especially cancer patients and hospice patients. It is really, really beneficial for them. We do want to teach these patients, however, that they are going to have some breakthrough pain, even with that really high pain medication on board, because we cannot ever take away pain 100%. A 0 out of 10 pain score, if someone has chronic pain, is not usually feasible. So we have to teach patients that sometimes there will be breakthrough pain. Fentanyl is very short acting, so it is out of the body really fast. It is used for, as I mentioned, round the clock pain control. It's also used in anesthesia in conjunction with anesthetic gases and things like that. It's commonly used for conscious sedation when patients are undergoing colonoscopies and things like that. Um, and it alters that perception of pain, just like all your other opioids. And with the fentanyl patches, it is important that we remember that they need to stay on for 72 hours, so 3 days, and we can reinforce them if necessary. We just don't want to put anything in between the patch and the patient's skin. And then we never apply heat or cold to patch sites because you can increase the absorption of the medication or decrease it with the cold. And so those are all things that I want you guys to know for fentanyl. Fentanyl often shows up on the NCLEX just because it is a heavily tested medication and we give a lot of it. Another thing is always to rotate sites and to always wear gloves when you are putting fentanyl patches on, because even just one little touch to the medication patch part of it can give you some of the medication, which can be dangerous. All right, now we need to talk about the pain ladder. As I mentioned, and as Annalise mentioned, we always start with non-pharmacological pain relief interventions if we can. It's always important to teach patients about massage and physical therapy and ice and heat and things like that. We're always going to go there first. So the World Health Organization has something called the pain ladder. This is how we step by step treat patients' pain. We start with non-pharmacological things like ice and heat and physical therapy, and then we move to things like acetaminophen, which is Tylenol, and NSAIDs. We do those non-opioid medications. Then we use our weaker opioids like tramadol, sometimes codeine. Codeine is often mixed with Tylenol as well, or some of our stronger NSAIDs like ketorolac. And then we move into things like morphine, hydromorphone, plus acetaminophen. And then we go to our fentanyl and our strongest opioids. So the point of this, and you don't have to memorize this, is just that we move from, least invasive to most invasive, the weakest to the strongest. All right, next one. So as I've mentioned, opioids are very habit forming because of the endorphin release. They cause euphoria, which is why they are they're easy to abuse. So there are 3 kind of tiers of abuse with opioids and with any medications that have this potential, like benzodiazepines. The first step is tolerance. Over time, as patients take these for multiple reasons or for days at a time or weeks at a time, they will develop a tolerance. Over time, those receptors in the body start to upregulate, and we need more medication to get the same response. So as someone takes opioids routinely, they will need more and more and more to get the same response and to treat their pain if it is chronic. So we will have those decreased drug effects. Then we move to physical dependence. Once they have increased the dose and they're taking it regularly, that's when patients become reliant on the medications and they will withdraw without it. Sometimes they can have mild withdrawals, sometimes they're severe. And the dependence might be physical or it could be psychological or both. And then we progress to the final tier, which is actual opioid addiction, when the dependence is severe and compulsive and they have to have it. They cannot go without it. That is when we call it a true addiction. Now, when taken normally and when given appropriately, opioids have a really low abuse potential, actually. Less than 5% of patients who are started on these will actually become addicted. It is not something that happens the minute somebody takes an opioid. So it's very important to teach patients to take these appropriately, and that they are good medications. They have a place, but we have to be careful with them. Pain control is important. And for many years, when I was in nursing school, pain was the sixth vital sign. It was something you always asked. And that is true still. We want to always treat our patients' pain because, as Annalise said, it gives them better outcomes after surgeries and after painful conditions. We have to treat pain. It is a huge physical and psychological stressor. So we always need to be treating pain, and it is not a reason to not give an opioid if we are worried about addiction. It is just important to educate. Now, to go a little bit further with the opioids, the ones that we've talked about so far are what we call pure agonists or mu agonists. So they are going to bind to those opioid receptors and they are going to produce that response. They're going to mask the pain. They're going to release those endorphins. So that includes your morphine, your fentanyl, your methadone, your oxycodone. All of those are pure agonists because they bind to the receptors and they produce those endorphins and they mimic that response. Now, we also have what are called partial agonists. These are the weak opioids like tramadol. Kratom is also considered a weak opioid. It's more of an herbal supplement, but it is considered an opioid, and it can be abused just as the opioids can. These are the weak opioids because they're partial agonists. They don't completely give us all the effects that the pure agonists do. Then we have a class called the mixed agonists antagonists. These are medications that are used as step-down medications when a patient has been addicted or dependent on opioids. So this is when we use things like Suboxone, which is buprenorphine and naloxone together. So we have an antagonist plus an agonist. So these are used to wean patients off of opioids, but not let them withdraw. It gives them a little bit of the euphoria. Some of these give a little bit of euphoria and a little bit of the pain control, but they step them down. And then we have our pure antagonist. This is the naloxone. This is your Narcan, your treatment when they have overdosed because it blocks those receptors and knocks the opioids off them. We also have one called methyl naltrexone. This is a newer medication. It came out probably around 2010 or so. I remember when it came out because it was a really big deal. It's given subcutaneously and it treats opioid-induced constipation. I had a hospice patient one time. She had colon cancer and she hadn't had a bowel movement in weeks and she was horribly, horribly uncomfortable. And she was on heavy opioids for pain from the cancer. And we gave Relistor. I pushed it through her insurance and I was really proud of myself and I got her this Relistor. It was pretty new to the market and she had a bowel movement within about 30 minutes and we both cried. She cried, I cried. We were so relieved that she had finally had this bowel movement. She was a little bit more comfortable. I will always sing the praises of that drug because of that. So methyl naltrexone is similar to naloxone, but it only blocks the opioid-induced constipation. All right, so those are our four types. So the rest of these we can kind of quickly go through. Methadone is one of those opioid agonists, but it's also a partial antagonist, and so it is a treatment for opioid addiction. You've probably heard of methadone and Suboxone clinics. Those are designed to get patients off of these opioids. Methadone is well known to treat pain, but it doesn't cause the endorphin release as much, so there's less euphoria. So it's less addicting. But it has the same nursing considerations as the other opioids. Make sure we're treating the constipation, increasing fluids. We're watching for respiratory depression. And then we're slowly titrating them downwards. That just means we're slowly decreasing that dose, and we're always monitoring for withdrawal signs and symptoms if you go too quickly. The others that we've talked about, your Suboxone, your butorphanol, these ones are also used for addiction and opioid withdrawal just to get people off. Same thing as your methadone. They're going to have the same side effects as your other opioids, and we have to monitor for those withdrawal symptoms. I just want you guys to be aware of some of the names of these. And then our opioid antagonists, like our Relistor or methyl naltrexone that I just talked about, that treat the constipating effects of opioids, plus our naloxone that treat um, our overdose of opioids. These are really, really important. But we are going to monitor for those withdrawal signs and symptoms. As I mentioned earlier, seizures can occur. They can be quite combative. They might be in a lot of pain. They might be really sweaty and shaky when they wake up. So we always want to be monitoring for that immediate withdrawal when we're giving these antagonists. All right, so now we're going to segue a little bit out of opioids, but we're going to talk about things that are related to them. The first thing we're going to talk about as far as pain control, and this is a really important thing that we can do for patients in the hospital. We can set them up with patient-controlled analgesia. Um, so PCAs are what these are called. PCAs are pumps that provide a continuous or a bolus type infusion of typically opioids for pain management. These allow patients to be in control of their pain. These are commonly tested about on the NCLEX because there's some really specific things we have to remember and monitor. When someone is dosing themselves with opioids, we're still monitoring for the exact same things we did with our other medications when we're giving them routinely. So you're monitoring for respiratory depression, you're monitoring for constipation, you're monitoring for all these things. But you're also monitoring the administration system itself. The pumps are always under lock and key, and you have to get the key from your medication cabinet, your Omnicell or your Pyxis or whatever it is. PCAs lock patients out at a preset maximum dose, so they cannot overdose on these if everything is set correctly. So I shouldn't say they cannot overdose because I'm sure that has happened. And I have had patients in the hospital who have tried to walk out of the hospital and tried to break the pump to get to the opioid that's in it. So we always have to be very careful about these. PCAs give medication either IV or through an epidural catheter, so they can be used either way. We have to have frequent vitals, and typically continuous pulse oximetry is always warranted because we need to know what their respiratory status is. We monitor for bradypnea, so monitor the respiration rate. If it's too slow, we need to reassess if they should have this PCA or not. Another important thing that the NCLEX loves to test on is only the patient should be pushing the button. The family should not be pushing it. Nurse should not be pushing it. It does not matter if it is lit up and it's time for another dose. If they're asleep, we do not push the button. 2 RNs have to check the settings and return the key to the pump to the med room, Omnicell or Pyxis, whatever it is. And then you have to have hourly documentation. And then at the end of the shift, you have to document how much medication was given total in that shift, and how many times they were locked out. So those are some common things that are tested about on the NCLEX and things just to be aware of with PCAs. And those usually have drugs like fentanyl or hydromorphone in them. All right, now we're going to segue completely away from opioids, and we're going to talk about our non-opioid analgesics. So these are medications that are commonly given with opioids to increase the pain control, or they are given over the counter for mild to moderate pain. So these are not always used with opioids. They are often used by themselves. And if any of you, have children, you've probably given quite a bit of acetaminophen and ibuprofen for, aches and pains and fevers and things like that. I know I have. All right. So with our non-opioid analgesics, our NSAIDs, our aspirin, and our acetaminophen, we have to talk about COX enzymes. COX enzymes are very active in the body and they help produce prostaglandins from arachidonic acid. Prostaglandins are part of our immune system and they are the precursors and first responders in the body, and they cause and help produce inflammatory reactions, fevers, and pain. So when we block any of these enzymes in any of these three pathways, there's three different COX pathways, then we block inflammation, we block fever, and we block pain. Now, COX-1 and COX-2 are the ones that are really going to block inflammation. And someone asked about COX inhibitors being a subtype of NSAIDs. So that's what NSAIDs are. NSAIDs are COX inhibitors. So yes, they are a subtype of NSAIDs, but all NSAIDs are COX inhibitors. Good question. So so these NSAIDs, these medications, they're mainly going to block COX-1 or COX-2. Aspirin is going to block those two as well. Now, acetaminophen works a little differently, and we actually don't know exactly how acetaminophen or Tylenol works. If someone ever really figured out how acetaminophen works, they would probably get the Nobel Prize. There is a ton of research around it, but no one has really pinpointed exactly how acetaminophen works. They think that it works on COX-3, but Tylenol doesn't cause anti-inflammation, and so it's hard to say if that's exactly how it works. Anyways, so we have these enzymes throughout the body, but COX-1 is mainly found in the brain, our bones, our platelets, and the female reproductive system in our uteruses and our kidneys. So this is why NSAIDs like ibuprofen are typically the recommended drugs for period cramps and things like that, because we're blocking those COX-1 receptors. Tylenol doesn't do that. It doesn't work on the COX-1s as much, so it doesn't cause that anti-inflammatory effect, and it doesn't help with period cramps as well. Now, everybody's a little different, so some people like one over the other, but ibuprofen and your NSAIDs are typically recommended for period cramps over your Tylenol because of that. Your COX-1 inhibitor or your COX-1 enzymes are also found in your platelets, which is why NSAIDs like ibuprofen and aspirin can increase bleeding times, especially aspirin will do this. So that is why we get the bleeding risk with our NSAIDs and with our aspirin. These are also, these COX enzymes are in the kidneys. When we block those, we can cause kidney injuries. This is why NSAIDs are the #1 cause of kidney injury. And we always have to monitor how many NSAIDs or a day these patients are taking, because they can cause kidney injuries. All right, so let's move on and we'll talk a little bit more in depth about our COX enzymes. So when we're blocking COX enzymes, as I mentioned, we're blocking prostaglandin production. Prostaglandins, as I mentioned, are part of the immune system. So when we block them, we are blocking that inflammation, we're blocking some of that pain from the inflammation, and we are reducing fevers. But prostaglandins are also really important in our stomach lining, and they maintain the integrity of the stomach lining of the stomach. So when we block that protection, we can cause gastric ulcerations. This is why NSAIDs and aspirin are really well known to cause GI irritation, and they can cause GI bleeds when they're taken in excess. So we are always monitoring GI status. We're monitoring kidney function, as I mentioned, because of the renal impairment that can come with these. We're monitoring bleeding times with NSAIDs and aspirin, and you can also get some vasoconstriction and sodium retention with NSAIDs. So we do have to be careful with the NSAIDs with heart patients who have coronary artery disease and hypertension. So that is why that is also included there. And let's move on to the next slide. So we're going to start talking about aspirin. Aspirin is technically an NSAID, even though we don't really lump it in with our ibuprofen type drugs. It is on its own. It's called a salicylate. So it is mainly used for mild to moderate pain, but it's also an antiplatelet aggregator. So it is commonly used to prevent strokes and heart attacks because it thins the blood just enough to reduce their risk. It also is sometimes used for things like rheumatic fever, and in pediatrics, the only time it's used is in Kawasaki's disease. Now, we typically stay away from aspirin completely in pediatrics because there is a syndrome called Ray's syndrome. Ray's syndrome is a potentially deadly syndrome that can occur after a patient has had a viral infection if they get aspirin within a certain window. So we just avoid it in kids altogether because of that risk. It's rare, but there is that risk. And we have other anti-inflammatories and things we can use other than aspirin, so we just stay away from it. Um, as I mentioned, aspirin is going to inhibit that prostaglandin production. That's how it treats fever and inflammation and decreases that platelet aggregation. So all the side effects are going to have to do with those things. So GI irritation, GI ulcerations if taken in excess, bleeding, so little microhemorrhages, petechiae, increased PT time. And then aspirin does have a toxicity to it. And a lot of these over-the-counter drugs are easy to overdose on because they are so accessible to everyone and children can get into it. If someone has overdosed on aspirin, it's called salicylism, and it causes nausea, ear ringing, headaches, hyperventilation, and eventually pulmonary edema, as well as acidosis. And we do not have an antidote to aspirin. The only thing we can do is treat the acidosis with bicarbonate to buffer the pH and to put them on a ventilator. And treat the respiratory depression. So salicylism can be very, very severe, and we do not want patients to overdose on these drugs. Because aspirin is an anticoagulant, or a mild anticoagulant, it's not a true anticoagulant, we want to discontinue it 5 to 7 days before surgery and make sure that patients are aware of the bleeding risk and not to fall, and to make sure that they are careful with cuts and scrapes and things like that to make sure things stop bleeding, and nosebleeds and things like that. Um, Baby aspirin is usually is what we used to call a low dose aspirin. It's 81 milligrams. We don't call them baby aspirins anymore because of the confusion with pediatrics, and we don't want to give this in peds. But low dose aspirin, that 81 milligrams, is usually the prophylactic prevention dose of aspirin. And then aspirin is contraindicated in pregnancy in the 3rd trimester, but occasionally they will use a low dose aspirin throughout the pregnancy to prevent things like preeclampsia and HELLP syndrome. So occasionally aspirin is used in pregnancy, but it is contraindicated in large doses, especially in that 3rd trimester. And that is actually because it can cause bone growth problems, as well as kidney issues. All right, so that is your aspirin. Now we'll talk about NSAIDs. So NSAIDs, this is a large group of medications. It includes anything from ibuprofen to meloxicam to ketorolac, which is our strongest NSAID. We also have things like celecoxib. This is better known as Celebrex. So a lot of these are over the counter, but ones like ketorolac are prescription. These are used for mild to moderate pain, except for ketorolac can be used for moderate to severe. These are anti-inflammatory. So these are the drugs of choice for osteoarthritis and any sort of inflammatory pain. They can also be used for rheumatoid arthritis in addition to steroids and other immunosuppressant drugs. And then these are the drugs of choice for painful periods, this dysmenorrhea over here. These are going to block prostaglandins through the COX-1 and 2 pathways, and so that's how they decrease inflammation, pain, and fever. Now, all of these are going to have similar pain effects, but they will have different anti-inflammatory effects. So for some people, naproxen might be a better anti-inflammatory than ibuprofen. It really depends on the person, but some of them do have greater effects than others. Some of these also have higher GI ulceration risks than others. Celecoxib has the lowest GI ulceration risk. It's a COX-2 inhibitor, and so it actually doesn't do as much on COX-1 as some of the others. And so we do just have to be aware that they are a little different that way. Now, as a nurse, you're not going to be choosing exactly which one to give unless we're talking about over-the-counter medications. So that will not be something you would be tested on in nursing school or on the NCLEX. Side effects of NSAIDs, very similar to aspirin, right? The GI problems, the ulcerations that can occur, and bleeding, prolonged bleeding. So these are avoided in anybody who might already have a bleeding problem, like surgical patients and trauma patients. With stomach irritation, we have to manage that closely and watch for black tarry stools and things that might tell us that they're bleeding from the GI tract. As I mentioned, NSAIDs are the #1 cause of kidney injury. So we really have to pay attention to their kidney function. And if somebody is in kidney failure, these are contraindicated because they will, or if they're in kidney disease, advanced kidney disease, these will make things worse. These also can cause water and sodium retention, as I mentioned. So they can raise blood pressure. So we are very careful with these in cardiac patients. And then there's a few really distinct times the NSAIDs are used that we wouldn't typically think of. One of them is in a patent ductus arteriosus. So patent ductus arteriosus, this is a hole between the pulmonary artery and the aorta that sometimes infants are born with. In utero, this is a very important thing because it allows blood to mix, oxygenated and deoxygenated blood to mix. But once a baby takes their first breath, the pressure gradient and certain chemical processes that occur after a baby has been born should close those holes, that hole. Same thing with the patent foramen ovale. But if those do not close within 24 hours or they remain open for much longer, we can give IV ibuprofen or indomethacin, and it actually closes those holes because those holes are actually kept open with prostaglandins. So when we're antiprostaglandins, we can give these medications and we can actually help the heart close up those holes and heal. So it is pretty dang amazing, in my opinion, that they figured that out because otherwise these babies would need surgery. NSAIDs like ibuprofen have to be really carefully used when a patient is on lithium. Lithium is a mood stabilizing drug. So it's used for bipolar disorder, mainly the manic side of bipolar disorder. And when given with NSAIDs, it can actually decrease how well our kidneys get rid of lithium. And so NSAIDs can cause lithium toxicity. So we want to be very careful with NSAIDs and lithium together. And then indomethacin off-label can be used to treat preterm labor because once again, antiprostaglandins, right? And prostaglandins stimulate uterine contractions. That's why NSAIDs work so well against period cramps. They also work in the big cramps in labor and delivery, right? So those are your NSAIDs. Those are heavily tested medications. Be aware of them. Be aware of those side effects. All right, acetaminophen. Acetaminophen is, as I mentioned, also an antipyretic, and it does work for pain, but we don't know 100% how it works. We think it works on those COX-3 receptors and possibly the hypothalamus, but we don't actually know. And it is kind of scary sometimes to realize how many medications we don't actually know what they do at a really, really base chemical level. We just know that they work, and so we keep using them, and we've used them for so many years that we kind of know what the side effects are. And acetaminophen is one of those. It doesn't have any anti-inflammatory action, so it's not the drug of choice for your osteoarthritis or anything like that. But it is used for pain and fever. And then it's often, as we've talked about, mixed with your opioids to give a broader amount of pain relief. Unfortunately, though, acetaminophen has some risks. Even though a lot of people take this very frequently, it has some risks. It is very, very hard on the liver at high dosages and when taken chronically. So we always monitor liver function. Toxicity of acetaminophen causes flu-like symptoms like nausea, vomiting, malaise. They just don't feel good. But then their liver enzymes will shoot way up. And that's when we are really going to get concerned because it will lead to liver damage and death from liver failure. So we have to be monitoring for that. There is an antidote to acetaminophen toxicity. It's called N-acetylcysteine. So it kind of sounds like acetaminophen, acetylcysteine. This is the antidote. It can be given IV or PO, but PO smells like rotten eggs and it's really hard to get patients to take it. Gastric aspiration and lavage is also on the table. We can put an NG tube down, suck things out of the stomach, saline lavage. They can also do activated charcoal, which is a treatment for any type of poisoning because it actually binds with the medication or poison or whatever it is, and then the body will excrete it. The max daily dose of Tylenol for anyone who's taking this intermittently is 4 grams per day. For anyone who has liver dysfunction or who's taking this daily for pain relief, we don't want to go above 3 grams per day to protect the liver. In peds, we don't want to go above 4 or 5 of their weight-based doses in a 24-hour period. So that is the max dose for acetaminophen. And then a lot of over-the-counter medications have acetaminophen. The next time you guys go to your medicine cabinet, I want you to look at any cold and flu preparations you have in there. Things like Robitussin, certain types of Robitussin, and you know, your off-brand cold and flu preparations will often have acetaminophen in them. So patients need to be taught to always check their labels and to know what they're taking, because they might take a prescription that has acetaminophen in it, like a Percocet, and then they take an over-the-counter medication for a cold and flu, and it has Tylenol in it, and they might get above that 4 grams. So we always have to be monitoring how much people are taking. And then anybody with any liver disease needs to just stay away from Tylenol completely. All right. Adjuvant pain medications. So these are medications that we add to our other pain medications to give even broader pain relief. So your NSAIDs and your Tylenol, those are often used as adjuvants. Aspirins can sometimes be used as an adjuvant. If they are mixed together, they're going to have all of the side effects of all the drugs that are made up in it. We always just remind patients that a 0 out of 10 pain is not always realistic, and it will decrease their drive to breathe. So we always monitor the airway. The next slide here, these are other medications that can be used for pain relief. We have some antidepressants, like tricyclic antidepressants that can be used for neuropathic pain and fibromyalgia. So these are drugs like amitriptyline, nortriptyline. There's other antidepressants like venlafaxine that is occasionally used for neuropathic pain, as well as Cymbalta. And now I'm blanking on the generic name of Cymbalta. I've forgotten it. I apologize. But those are sometimes used, those antidepressants, because they work on some of those neurotransmitters that can block or kind of change the perception of pain. Clonidine is another medication that is sometimes used for pain relief. It is actually routinely used as an antihypertensive, but it does block some of the effects of certain neurotransmitters that relay pain messages, and it works on the fight or flight response, and it actually releases some endorphins. And so so clonidine can be used for this as well, but we always monitor for hypotension with that drug. Duloxetine. Actually, I think this is Cymbalta. I think it is on here. Okay, so duloxetine. This is another antidepressant. It's called an SNRI because it increases our norepinephrine and our serotonin levels, and it is also used a lot for neuropathic pains and things like that. Gabapentin and drugs like pregabalin, this is Lyrica, if anyone's ever heard of that one. Those are commonly used for neuropathic pain. These are really commonly used in people who are diabetics, who have the paresthesias and different things. And also these can be used in post-herpetic neuralgia after a patient has had shingles, if they have severe pain. So those are commonly given. And then we have things like lidocaine patches. These are really good for local anesthesia. They give us a lot of just local pain relief. And then we have things like Icy Hot, if anyone's ever used Icy Hot, that contain certain things like capsaicin. These are your Bengay type of medications. And actually these are related to aspirin, some of these topical pain relievers. You can get topical NSAIDs as well. I saw somebody ask about Voltaren gel. That is actually a topical NSAID. So a lot of these medications can be used in topical forms, and they will reduce inflammation, and they do have fewer side effects when we give topical versions of these pain medications. Your local anesthetics. So we talked about our lidocaine patches. Local anesthetics in general are used in acute situations when we're trying to numb something, but they can be used in creams and patches like we just talked about because they block those sensory fibers and they block that pain relaying. Um, Fun fact, cocaine was actually a local anesthetic. It was the only naturally occurring local anesthetic. But once we started developing it as anesthetic, people started abusing it, and now we only use it topically. I actually laugh every time I have to pull cocaine out of the Omnicell at work. We only use it topically, and usually it's only for ear, nose, and throat bleeding. But it's actually just kind of fun to pull cocaine out of the Omnicell, and I feel kind of, cool. But don't abuse cocaine. So just be aware, anything that ends in cane is a local anesthetic, and these can be used as pain relievers, but typically in acute situations, unless we're doing the creams or the patches. There is a cream called EMLA. This is a eutectic mixture of local anesthetics that is used for portacaths and lab draws, especially in pediatrics where they are afraid of the needles and it hurts. We can put this numbing cream on the area before we stick them so that they don't feel it as much. You just wipe it off right before, you let it sit there for a little bit and then wipe it off, and then they will not feel, or hopefully won't feel, you poke them for the lab draw. This is a huge comfort to some children and some adults who really, really don't like needles. So the canes, anything that ends in cane, just remember, is a local anesthetic. And we won't get too much into the toxicity and things like that just because we're running out of time and because those are not commonly seen when these are used for just minor procedures and things like that. All right, we also have muscle relaxants. So these are things like baclofen and methocarbamol and crisaprolol, soma. There's a lot of these muscle relaxants. What these do commonly is they just block the neuromuscular junctions and they just calm down our muscles. So these are commonly used for patients who have MS, who have cerebral palsy or any spasticity conditions. These can also be used for severe back spasms and things like that, but we always monitor, just like with all our other pain medications, especially our opioids, for CNS depression and any airway problems. You're also monitoring for um, toxicity. So paralysis of those respiratory muscles is going to be the biggest thing that we're going to be watching for. We also have some kind of outliers here. Botox is actually a skeletal muscle relaxant. That's how it treats wrinkles and things like that. But it's actually a toxin. It comes from the botulinum bacteria, Clostridium botulinum, and it causes botulism if we'd let it. But when we use it just superficially, it gets rid of wrinkles. But pharmacologically, it's more important to help with spasticity disorders, especially those with cerebral palsy who have contractures and different things like that. So Botox injections can be used medicinally and not just for cosmetic reasons. So those are some interesting things about your skeletal muscle relaxants. All right. So that is the end of our lecture for today on pain medications, everything from opioids to NSAIDs, your aspirin, your acetaminophen. Does anybody have any quick questions before we end? Probably bored you all to tears. Pharmacology is not always the most riveting subject, but it's very, very, very important that we understand how to give these medications safely and how to teach patients to take them safely. So I appreciate all of you guys. I'm going to hand over control back to Annalise.
Thank you, Lauren. That was wonderful. I learned something every time you talk to me. So that was a really great refresher on pain medication. Because, like I said, guys, at the beginning, there is not very much we can do for our patients and clients more than managing their pain well. It increases every outcome in our clients when we have well-managed pain. So set those SMART goals with your clients ahead of time about what a realistic goal for pain is. I mean, my grandma's been in chronic pain for like a couple decades at this point, and if you asked her, she'd be like, well, I'd like to be at a pain level of 0. So it's recognizing sometimes that a client's expectations may not be realistic. And maybe we need to say, okay, well, we can't get you from a pain of 10 down to 0, but maybe we get you to, like a 5, something that's more manageable using both non-pharmacologic and pharmacologic intervention. So thank you again, Lauren. That was wonderful. Thank you guys for joining. Again, if you want to see more of Lauren's content, more of my content, and just more information in nursing school and short little lectures like this with cheat sheets and Q banks, you can sign up for Archer for Nursing School online at archreview.com. So if you guys have any questions, feel free to reach out to us. I am happy to answer anything.